So we're recording now. Welcome. I'm Susan Blum, as you all know. Welcome to my home office. Sometimes I'm facing the other direction, so I seem to be having the desire to change it up a little bit. It's Friday morning, April 17th, and it's important for me to give you the date because things keep a-changing, right? Things are a-changing every day or every week. There seems to be new information. So my goal of my Friday office hours are two things. As you know, every Friday I come out with about a half an hour of, and maybe today it'll be a little shorter, I hope so, because the questions that I answer seem to take a full hour or at least 45 minutes. So but I feel the need to give you my interpretation of what's going on and what to expect and plans, so interpreting what you keep seeing in the news about testing, treatment, the public health initiatives. And so let's just jump right into that. So welcome, and here's what I want to talk about today. In terms of, let me get my so I of course wrote it. I got myself all organized, and I have my cheat sheet to follow. And so the first thing I want to talk about is just the public health piece, because yesterday the federal government came out with their guidelines, which are just guidelines for the states to follow for how we're going to get out of our houses, right? Every week you guys ask me, when are we getting out? What, how long is this going to last? And so with their public health sort of officials, the federal government had a press conference yesterday and announced sort of the rules for their recommendations for how we're going to get out of our houses and understand and getting back to quote unquote normal. And the first thing to keep in mind is that one of the most important parts is that it's really up to the states, because every state's going to be different. Every state is on its own curve in the epidemic, right? And so one of the very first things, so the first thing that needs to happen is they call it the starting gate. You have to get out the gate to even start. And there are certain guidelines for what the public health officials, so Dr. Birx and Dr. Fauci, have recommended as what's required to even get out of the gate, to even change a thing. And those two main things are 2 solid weeks of declining people getting sick with symptoms and showing up at the hospital, hospitalizations, infection rates, right? And ICU admissions, like all of that. So it's symptoms, diagnosed cases, and hospitalizations. You have to have 2 solid weeks in a row of it going down. And there's all sorts of terms we give that. And there's this thing, this row naught, which is like how the infectability, for one person, how many new cases are there for one current case. And that needs to be below 1, right? Right now, at least as of yesterday morning, New York was at 0.9. So we dropped below 1. So New York is starting its 2-week period, I think, starting probably yesterday is my guess. But I could be wrong in how they're going to count those 14 days, which is, again, a big part of this. Like, you have to fulfill all 3 of those criteria. People that have symptoms, people that are diagnosed cases, and hospitalizations have to be going down for 14 days. That's the first thing. And so every state is going to reach that hurdle in a different way. Some states still have it, it's still on its way up. And so, depending on your state and where you're at, you might reach that hurdle, which will be great. The second big thing before you even get out of the gate is you have to be prepared with surveillance. And this is what I've been talking about every week. For those of you, this is my 4th week, I think, right? And so all of you have been, hanging out with me on Fridays. I've been talking about surveillance from the beginning. I have my master's in public health. I understand what that means. And that means we can test. We have to be able to find the cases and trace their contacts. And so that's testing. In order to find all the cases, you have to be ramped up with testing. And then you need an army of public health. You need an army of public health folks. You need to hire a public service corps, which is now what I'm reading about. Some people are talking about creating a public health, a medical service corp of public health boots on the ground. You need somebody who's going to contact trace. You need whoever's diagnosed, somebody's got to call them, figure out all the people that they were in contact with, and then find all those people and you quarantine the cases and their contacts, and those people stay home. That's the next stage in an epidemic after mitigation, which we're coming out of now. And so how do you do good surveillance? And so that's really the question. So to get out of the gate and even move to phase 1, for 2 weeks, you have to be on the downslope and you have to be readiness. It's called preparedness. And that is, again, a big sort of mishmash, depending on who you talk to and each state, because there's really no guidelines for how much testing do you do. And it seems to me from what I saw in terms of these general guidelines the federal government is giving us, is that they're not really pushing too much for testing, and that they sort of want us to lean into the classic way that influenza. I get a weekly email from New York State Department of Health with the influenza report. And there's surveillance that we do for influenza. That's something we have always done. But everyone doesn't get an influenza test. It's people who show up with the respiratory symptoms. And so there's a surveillance process for just symptoms. And I think that there's some discussion about allowing us to use that kind of system for surveillance instead of requiring that we have testing to really track everyone. And so to only go by symptoms and using the influenza system, that worries me. And I'm hopeful that our governors are not going to accept that as okay, which just means that to be prepared to move out of the starting gate and get into even phase 1, in addition to watching the curve go down, which a lot of us are starting with, certainly in New York we are, and that this preparedness thing is taken to heart by all of our governors, that they make sure we have adequate testing and adequate public health officials that are working to do contact tracing. Because in order for us to leave the house, I've been saying this for a month, everyone who's sick and all their contacts and who have it have to stay home, and we have to identify them. And so that's the whole starting gate that they called it. And I don't know where we are on that. I mean, I'm hopeful that, if I can only speak for New York, all of you should look on your state government, the governor, there's websites for your state, and they can talk, and you will see your governor talking about this. Cuomo's been talking about this, and I'm hopeful maybe in 2 weeks, the testing is going to be there. I'm a little concerned about that, but there seems to be an understanding about how badly we need to get the testing done. And hopefully, it's without the central leadership, it's sort of hampered everybody's abilities. But I'm not going into politics. This is straight from public health. The way we're doing it is just, it's not facilitating getting the testing done like we need to. On the testing front, and this might really help, so breaking news, Rutgers University has created a saliva test, which they think is, they're in the final stages of confirming is really accurate. And now we have to find a way to scale that, because saliva testing is great. You can send it to people's houses. You can do kits. You don't have to do that in a doctor's office. A lot of my functional labs that I use have saliva testing. I use saliva testing for adrenal fatigue. Some of you who work with us know we do saliva testing. And so there are labs out there who are perfectly set up with kits that collect saliva. And so, and genetic testing has often been done with saliva or a buccal swab, right? So I'm hopeful that maybe that test will be scalable, because it won't need as much resources. There's been a limitation because of swabs that we don't have enough swabs to do all the COVID testing. So the new saliva testing might be a breakthrough, so we can really ramp that up. I'm trying to figure out, I'm sure I will hear from one of my testing companies if they start offering a saliva test, and I will let you all know if we get that. And so that's the starting gate. And then I'm not going to I don't want to spend too much time on phase 1, 2, and 3, but I'll read very briefly so once you get through 2 weeks of that starting gate, you're allowed to move into phase 1. And what that means is people who are high risk still stay home. Okay. And it turns out that obesity, or being very overweight, is the number one most important risk factor. And part of that is also because of people that are obese, by definitions, of how much you weigh and your BMI, people who are very overweight tend to have an increased risk of diabetes and hypertension and heart disease, which are the 3 things that are correlated with getting very sick from this virus. And so in phase one, basically the change would be that you're allowed to get together with less than 10 people. So there's this magic number of 10 people instead of 5. The number goes up. You're allowed to start traveling, limited essential travel, limited travel for work. So some of that starts opening. Telework, working from home is still encouraged, and all employers are told to keep doing that with people if they can. But you can open up businesses and have staggered sort of work. People return to work in phases. And this is where immunity testing will be really good, because once we know that you have antibodies, then and we know that you have antibodies that are protecting you. And those studies are still being done, right? That we have to make sure our testing is good, and that our testing tests for protecting antibodies and not just any antibodies to the virus, and that you can't get reinfected. And I think in another few weeks, we're going to have more information about that, because there is definitely studies, especially in China, being done on trying to reinfect people with antibodies to see if they have it. But definitely, so the list: continue social isolation, continue social distancing when out. So even in phase one, you're going to still wear your mask, and you're still going to stay away from people. And I think people are afraid of other people now, so we're not getting too close with anyone anytime soon. The vulnerable stay at home, less than 10 people gathering, limit non-essential travel, but it's permitted but limited. Return to work in phases and encourage telework. When people are at work, so in the workplace, the guidelines are to close the common areas, right? So no more collecting at the water cooler, no more sitting and having, lunch together in the staff kitchen. The schools are going to stay closed if they're already closed. That's in phase one. No visiting nursing homes. Large venues can open with very strict guidelines, and that's the devil is in the details, so they say, but they're using this term strict guidelines because in phase two, they moved to moderate guidelines. So things loosen up, but they're saying large venues could open with strict guidelines. Gyms can open with strict guidelines. Bars stay closed, and elective surgery gets opened with outpatient only. So that's my list. And you move into phase one. So you have this 2 weeks, you have to meet the criteria for getting out of the gate. And then you move into phase one. And you do phase one for a minimum of 2 weeks, and you have to see the curve continue to go down, no rebound in cases. You have to make sure the hospitals are not getting more cases, and your hospital, this is the other part actually that maybe I forgot to mention, that in terms of preparedness, not only is the surveillance system in place for testing and contact tracing and public health officials, but the hospitals have to be ready. The hospitals have to have capacity again. They have to room in the emergency rooms, room in the ICUs, and ready in case there's another surge. And so the hospitals have to be ready. And so you move into phase one. If all that's playing, you move into phase one, and you do that for a minimum of 2 weeks, and you make sure that you assess it again, and you say, are the hospitals still ready? Are we doing our testing and contact tracing? And are our numbers still going down? Is there no rebound? You can't see a rebound in the numbers or a rebound in the hospitals. If that goes on for 2 more weeks, and unfortunately, I don't know, 2 weeks is long enough to be ready to say that, that's okay to move to phase two. They're saying like you have to go through another gate, which is another 2 weeks of period of another gate, and then you get to move to phase two. And then the guidelines loosen even more. So less than 50, instead of 10 people, you can go up to 50 people can gather. All non-essential travel becomes okay. So you can start traveling. And schools, and then the new things that can reopen are schools. The large venues get looser restrictions. You can have inpatient surgery, and the bar is open. And so if everything goes swimmingly beautifully, that would mean if New York applied this, and if once we get out of the gate, which I don't know we'll do in 2 weeks, even though our curve's going down, because we have to have preparedness, right? Let's say we're prepared in 2 weeks. We have 2 weeks to get out of the gate, and then we go to phase one, and then another for phase two, which would mean they want to get the camps open, which would mean that in a month or come June, that camps and schools and things like that would be in phase two, that they could be open. In all these phases, and then phase three, and then you do that for another couple weeks, and then phase three, everything opens. But the vulnerable people are always going to be told to stay doing 6 feet away from everyone, social distancing, maybe even wear a mask. I actually think through all this, we should all wear masks. I don't know when I'm going to stop wearing a mask in public. I think we should just all continue to wear masks. I think this is really, really ambitious. I think 2 weeks per phase is probably way too little, because it takes 2 weeks to even start seeing a change. And so my guess is each phase might be longer, depending on what the governors do. But it's an interesting kind of structure that was laid out. There's so much that needs to happen to allow each step to go. And the federal government's washed their hands of it. Said, this is what we think you should do. Now you governors can figure this out. And so the problem is, with the preparedness piece to even get out of the gate, I think a lot of states are going to struggle to do that. And so that's my update. So that's my interpretation. At least I think there's a lot of, it's really cool to be able to see what the path is. And I would say that in general, that probably is sort of the path. But the how to accomplish it is 100% left to your governor. And the how to. Like, how are we going to get there? There's so many things that need to happen on each of those steps for the how to. We need PPE for our doctors. The hospitals have to be ready, right? To be ready for another rebound in order to. And so certainly, anyway, so I don't want to riff on that too long. I want to move on. So that's the story with that. So it's a nice structure, but rather than it taking 2, 4, 6 weeks for us to become normal, which would be phase 3, 6 weeks or 8 weeks, depending on, if everything goes swimmingly well, you're looking at 6 weeks. I think the whole process could be more like 3 months. And my guess is that under a scenario like that, like this does not allow the virus to completely disappear. It's not like it's going to go down to 0. My guess is what's going to happen is there's going to be sort of a low level of infection that's going to percolate in our communities. And it's going to be just tamped down. So we're going to have chronic low levels of people getting infected, because we are going to open up. And the goal is not to allow that to overwhelm the system, not to have a steady state that's sort of low and below, at a low enough number that it stays down and doesn't start rising. Because as soon as it starts rising again, that's called a rebound. And I'm sure the definition of a rebound will change. But I think that there's going to be a low steady state that we're going to stay at until we get some sort of really good treatment. Which brings me to treatment. So that's public health. Let's talk about treatment. There's actually a couple of good news things on the horizon. Yay, right? So I've been reading a couple of good results of studies using remdesivir, which is the antiviral medication. Now, so right now, in terms of treatment, people who are really ill in the hospital are being put into 3 buckets, right? They're being offered 3 different things. And we're studying which ones are most successful. The first is the antiviral, and they're using remdesivir is the main one. That's the one that they're hoping is very specific for this particular virus. And it's looking promising. Like it's people are getting better quicker. So my fingers are crossed for that one. That would be great, okay? And mind you, these things are not cures. What the goal for the very ill, these 3 trials, these 3 buckets, the goal is to decrease mortality and morbidity, to get people to decrease the death rate. And the goal is 20 to 30%. Like, if we can really cut the sickest people from ending up not making it, that's really the goal of these trials. And these medications, they're not cures. They're really to decrease mortality. And so remdesivir looks really promising. The one that's being studied to reduce the cytokine storm, the anti-IL-6, is tocilizumab. And that one is the other big one that there are trials going on for that one, and for people who are really sick, trials going on for remdesivir, and trials going on for convalescent serum, which I've been telling you about for a few weeks. And so the hospitals and the New York Blood Supply, you can just Google where to volunteer, to donate my blood if you've had COVID. So if you've had COVID, find a place to go. I've been getting emails from all different places saying, please tell your patients to go donate their blood. If you've had it, if you know you were sick, you should go get screened to see if you have robust antibodies. And then you can go and donate your blood, and they'll test it and they'll tell you. My brother-in-law who had it, He just went and found out he has really good antibodies, so they're going to let him donate blood. And we're using the blood from people who had it and giving it to very sick people. And it is helping them. It appears to be working to help people who are very ill to come back, right, and improve, which tells us that the antibodies are protective in some way because it seems to be helping people. So there's a big trials, and that's being done in all the New York City hospitals anyway. So those are the big things: remdesivir, the convalescent serum, and the cytokine storm medicine, tocilizumab. I'm sure I'm pronouncing that wrong. It's one of the UMABs. It's an IL-6 and suppressor. Interestingly, Plaquenil, which everyone got all excited about, it doesn't seem to be doing, we're not really sure it does much. The jury's still out. The jury's still out. It's still being used in the hospitals. I saw something that showed the end, it didn't really shorten hospital stay, but people had less symptoms maybe. So we don't really, I don't think Plaquenil is certainly not the thing where anyone's using for the very ill people. The other big news on treatment and ventilators and all of that is that I'm sure many of you have been reading this, that in terms of treatment, and this is really promising, they're realizing that that the lung injury, we've been all talking about ARDS, acute respiratory distress syndrome. So ARDS is, so the ventilator settings they've been using is pushes the air into the lungs. But there's a whole subgroup of people, it looks like there's two different kinds of buckets of people who end up having shortness of breath. One is a group of people who look like they have acute altitude sickness, and it's called HAPE, high altitude pulmonary edema, HAPE. So there's HAPE people, and then there's the ARDS people. And I was just reading this morning an article about from the intensive care unit, people, the intensivists and the journals there. They're all talking about, and it's been brewing for the past week, but now there's actual more valid sort of data coming out about this, that there's sort of what they're calling the L type and the H type of the different patients. So when people have to go, or they start desaturating and the oxygen saturation goes down, you have to determine if they're the L type, which means they need low pressure. They have sort of all these low markers. They just need to be treated like a high altitude sickness person, which means lower ventilator settings, more oxygen. And then there's the H people that need the more high intensity pressure kind of settings like ARDS. And now that they've started triaging and treating different people differently with the respirator, we don't need as many ventilators. We have not run out of ventilators. And actually, New York just sent 100 to New Jersey. So we have ventilator capacity. The demand on the ventilators, I think, is going to go down because we're realizing there's different ways to oxygenate the people or to treat them that have this high altitude pulmonary edema kind of pattern. And so that's really good news. And so, and people are doing better if you treat them that way. And then the other interesting piece to that that's starting to get a little traction is, what about treating people with acetazolamide, which is Diamox? For those of you who travel to altitude, you might know you've been given this medicine before you go, which helps you prevent pulmonary edema. And so I haven't seen any studies or anybody starting to use Diamox. That's just the trade name, but it's acetazolamide is the generic name in the hospitals. But I think that's going to be the next great thing. And the question really is, do people start out with the high altitude version, HAPE, and then if they progress and get worse, they end up with ARDS. And then they're wondering, did everyone end up with ARDS because the people with high altitude pulmonary edema symptoms were put on the respirator with those, and the respirator gave them the lung damage that ended up showing ARDS. So really interesting, good stuff. And so I hope you're not all, look, I know you're not all medical people, but I always promise to bring you and translate the latest stuff. Translate it to you. What does this mean? It means that I'm sort of optimistic that in the next month, we're going to do much better treating people who are very sick. And so as we venture out, I think I'm hoping the antiviral really turns out to be promising. And I'm hoping that understanding what's really happening in the lungs of these people are going to end up allowing us to treat them a little differently, which will have a better outcome and have less morbidity, meaning less people will die. You know, right now, about 70% of people that end up on a respirator die. They don't come off. And if we can drop that to 30%, that would be like a home run, right? So it'd be so many less people dying from this disease. And so I believe in our, like, so there's a worldwide, so one of the beautiful things that's happened with this whole epidemic and pandemic is our scientists and our doctors and our healthcare people, they're talking to each other from around the world. Even if our global leader, even if our leadership, or, you know, our, who knows what's happening at the top level from our country, our scientists are working together. Our people do, they're all in it together. We're trying to figure out treatments together. We're sharing data, we're sharing studies, and it's a global effort. And everybody's sharing, which is a beautiful thing. And so and a lot of these studies, the studies on the respirators and the high altitude pulmonary edema, that's from Italy. And the studies looking at, the study on remdesivir is out of China. And so we're like, everyone's collaborating. Okay, so at least the study that I just read that had like data on that, I think it was China. A Plaquenil, or maybe the Plaquenil study just came out of China, but we're all working together. And I'm actually starting to feel a little optimistic. We're not there yet, but that's the way. In the fall, we come out of this if we have really effective treatment, or at least treatment that's somewhat effective. And so, you know, to reduce our mortality, so we're not all afraid that if we get this, it could kill us, right? Because that's what the fear is about. The overwhelming majority of people come through this and they're good. Okay, come through this and you'll end up with antibodies. You'll end up immune. That's the most likely scenario for the overwhelming majority. But there's a small percentage of older folks who are very overweight, and who, especially if you have the other comorbidities that we call it, diabetes, heart disease, hypertension, and any lung disease. So interesting. I do want to say this too, for my folks with asthma out there. It's looking like asthma doesn't increase your risk. And everyone's scratching their head going, why are asthma people okay? And I think it's really because it's more the obesity, hypertension, pulmonary, cardiopulmonary disease piece that's related to metabolic syndrome and the people that are diabetic. That's more important than, you know, as you know, the asthma people, not, you know, don't overlap with that group of people. So I read recently that asthma doesn't seem to be in the high risk group. So that's good news for you folks out there. Okay, so let's see. So I talked about all the treatment and the new ideas of maybe Diamox is gonna, you know, high altitude sickness, adding that to the list might help prevent people from ending up with acute respiratory distress, and the change in how we're using the ventilators. In terms of my last piece about testing, so testing, and then we'll move into questions. In terms of testing, there was this new saliva test for the virus testing, and if that works, that's going to be great, because part of the thing that's held up our ability to test everyone for the virus is not only the different pieces of the test, like the swab. I'm going like this because you need a swab to stick up your nose and put in your throat. But the way the test is done, did you stick it in far enough? Did you get it down your throat far enough? And these are not things you can do yourself at home. Saliva testing would be relatively easy and relatively hard to screw up, so that those would be kits we could send to you. And so I'm looking forward to hopefully getting those. The next big thing in testing is immunity testing, which is the antibody testing. And we're still figuring out, and in the next few weeks, I think by the time, in another month, I think we'll have really good, we'll be able to definitively answer the question, maybe even the next 2 weeks. Can you get reinfected again? They're busy doing those studies in China. Based upon other viruses, we really don't think so, and part of the reason we don't think so is because the blood of somebody who's recovered is helping the people who are sick. So we believe that means that there are antibodies that fight the virus, and that if you have those antibodies, it will protect you. And so we're you know, public health folks and scientists want to make sure we 100% know the answer to that. But for now, I think it's really good to get immunity testing. One of the things it can do, the antibody testing, it'll tell you, did you have it? For those of you who never got tested, for those of you who had a sore throat and you're not sure if that's what it was, for those of you who think, you know, I was sick the first week in March, I wonder if that was it. there's so many people just curious. And we have antibody testing in the office, and I've had 2 people now that I've tested that had a little something, but didn't know that, and never got tested then, that turns out that they actually are positive. And so I think that, and I tested myself because I really just wanted to know, make sure, and I was negative, but I never had an illness since this all started. So that's the thing about the antibody testing. It's coming. And so here are the kits. And so I want to just tell you all what I have available, because a lot of you are my patients right now. And so I want to share this with you. And so I'm actually going to share my screen for a second. And so bear with me for a second. Whoops, what'd I just do? Okay. All right, now you can see my screen. This is the resources that I have for you. So I just want you to know what's happening at Blum Center. A lot of you have been calling and asking me, especially since last Friday, so I put it up on a slide here. Actually, I can make the slide even bigger. So here are the resources that I have at Blum Center. And if you see a functional medicine doctor, you have someone you already see, you might ask them what's up with them or what they're doing. But right now, there's a company that we use that offers a home kit that we could send you the kit, but you have to schedule a phlebotomist, a home traveling phlebotomist, which they have a list of 1,000 they work with all over the country. We can send you the kit, and we can send you the link to schedule with a home phlebotomist. And all that means is they will come and draw your blood at home. So for those of you who really want to do it right now and are okay with having a phlebotomist come to your house, and so they're all screened and they're all taking precautions. And so if you're game for that, I think it's fine. If anyone's interested in doing that, there are 2 ways to do that. And I wrote that here so you can see this. Please write this down. If you're an active patient at Blum Center, an active patient means I've seen you in 2018, 2019, or 2020. You're an active patient in our EMR system. All you have to do is email June and tell her, I want to do the antibody test. She will take your information, and we just go on the website and just put in the order for you. It's $150 for a kit. You can order as many as you want for you and your spouse or your partner or your kids or whoever, your parent, whoever's in the house with you, or whoever you want to do that. The kits are $149, it's $150. The phlebotomist is $100 for the first person, and then $50 for each additional one that the phlebotomist does when they come to your house. So, it doesn't cost nothing. I think eventually the antibody testing by July, maybe we'll have it available to the public where we can send you to Quest and LabCorp. It's just not going to be available, I think, for a month or two, for a couple of months. We just don't know when. Right now, Quest and LabCorp are overwhelmed with trying to get the COVID testing done. That's their priority, and they haven't moved to antibody testing. Now, a lot of people have asked me if you haven't been to see us since 2017 and before, then you have to sort of behave like an inactive patient or a new patient. And so if we've never met you and you've never been to Blum Center, I've been getting emails like right and left with people saying, can I get the test? Can I get the test? I can't give you the test unless you're a patient of ours. But I made it really easy to help you become a patient. And we can just do a 15-minute screening call with our nurse practitioner. So you can email Ariel at admin, it's up on here on the screen, admin@blumcenterforhealth.com. You can ask for a 15-minute screening call with the nurse practitioner. It will cost $100, which is what her time costs us. And we will put you in the system, you will become a patient. We need to collect data. We need to find out if you were sick, if you were, who was sick around you, did you have exposure, did you travel, like all those screening things that you had to ask for the original testing. We need to keep track so that we can collect data on all the people who are positive and see who was sick, right? So we need to do our part from a public health perspective. So we need to do an intake for you. And so we need to do that. And so we need you to become a patient and be in our system in order for us to be able legally to order you a test. And so you can email Ariel at admin and you can find out more information about that. So that's what we can do in right now, this moment. What's coming next, which I think will come in another, I'm expecting this to come in another 1 to 2 weeks, is the same company we're using for that's doing it by blood, and they have an emergency FDA approval, this company, to do it. They're do-it-yourself. They're preparing a do-it-yourself finger stick kit, because this company actually does finger stick testing for food sensitivity. We've used them for many, many years, and so they're just switching over, and they're going to do finger stick antibody testing for COVID instead of finger stick antibody testing for food. And so they're going to have kits to send out to your house, so you will not have to do a home phlebotomist. You can just get the kit, send it in yourself. And so I'm expecting those to be available to order in the next 1 to 2 weeks. And so we will certainly announce. So if you're not on you're on my mailing list because you're here seeing me today. And so, I mean, you're in my office hours, so we have your email address. We will send it. We will let people know when we have the finger stick kit. I will certainly let you know every Friday. And you can, or you can even email the admin, or you can email June and let them know that you want to get on the waiting list for the finger stick kit when it comes in. And so you can so those are your two people to email. Same process above. You can email to get the blood draw at home now with the phlebotomist, or you can email to be put on our waiting list for your finger stick test kit. Two different emails depending on if you're an active patient or you're an inactive/new patient. Okay. I'll put this up somewhere. I'll figure out where I can put this up somewhere, but I'm going to come back to myself here. Okay. So, maybe, I don't know, I'll ask Sarah, I'll ask my team how I can send out that information to everybody on this list if you have more questions. So that's it. I'm going to jump into answering questions now. And certainly if you have questions about that, I am offering this up as a service. I think it's really important. I think it's really helpful to know if you are positive, if you have immunity. If turns out you have immunity, and as we learn more and more, we're going to know that you can go back to work. You can do the grocery shopping for your family. You can not worry. You can go visit your grandmother, because you're not going to bring it. And part of that is, and by the way, if you are antibody positive, we do have to make sure that you're not transmitting the virus. So this is the other reason we need to do it as a patient, right? Because if you're positive, then we need to sort of counsel you on what that means, because there's IgM antibodies and there's IgG antibodies. IgM are a more recent infection. IgG means you've probably got infected a month ago or so, at least 3 or 4 weeks. If you're IgG positive, probably you're not infectable. You're not going to infectious. But if you're only IgM and you're not IgG, you might be. So we need to sort of guide you. We might want you then to do the COVID test if you're only IgM positive. So it's hard. You need to do this with some medical guidance, which is why we can't just send you kits. And so for anybody who's positive, we will definitely guide you. As long as you're a patient of ours, you become an active patient. Okay. So that's really why it's not as simple as just we can order it for you and then off you go. You're going to have questions, and then we need to guide you to interpret the results. Okay. Let's go to questions now. All right, everyone. So sorry, you see, I always have so much to say for the first part of this. There's just so much information to give you all. So I have 3 autoimmune disorders. Is it safe for me to take astragalus? Sorry, I can't answer that because it depends on what kind of autoimmune disorder you have. Generally speaking, there's 2 different buckets of autoimmunity. There's Th1 dominant and Th2 dominant. Th1 dominant are the natural killer dominant, the people that are upregulated in their natural killer system. Those people tend to be in general, those are the people with lupus, Sjogren's, scleroderma, polymyositis, dermatomyositis, the rheumatologic, positive ANA, rheumatic diseases. That grouping tends to be the high natural, the Th1 dominant autoimmune diseases. That's what we call it. In that group, I tend to not recommend natural killer cell boosters. So astragalus would be one of those. If you're in that bucket, I would say probably not. Next question. Do we have any results on people who are immune compromised, how they've done with COVID-19? It's interesting. I really, in all that I read, I haven't seen anyone talking about the people on prednisone, the people on immune suppression. They're really more and more and more. It's people who are obesity is actually that's what I've been reading for the past 2 days, is that it's even being more narrowed down, that obesity is really the biggest risk factor. And so, yeah, and so I'm not reading about immunocompromised. It just makes sense it would be an issue, but we're thinking that there's something going on with this ACE receptor, that we talked about before, that is somehow changed in people with metabolic syndrome, in people who have heart disease, or people who will be compromised by low oxygenation, in the heart. We're seeing that the heart is getting damaged, and in people who are very sick, and who have died. And so, the low oxygen and the metabolic syndrome piece is looking like it's more important. With regard to my question last week about viral load, I see indications for HIV, but I'm speaking about people with low IgA, chronic fatigue syndrome, Epstein-Barr, autoimmune, etc. I see patients with these conditions, and for me, I have all of the above and had hairy cell leukemia followed by Lyme, then staph, which almost killed me. I'm looking into a periomics. A periomics is the kit that I'm using for testing COVID. It's a throat swab, so you can do that. And SIGA as a way to help people differentiate present immune integrity. Well, periomics does other kinds of genetic testing. Am I on point? Well, I believe that this question is related to, remember last week when I talked about overall immune terrain, and I talked about, um, you know, so people that are getting COVID disease, right, and getting really sick from COVID disease, it's a combination of the virus plus your sort of social factors that put you at risk, plus your biologic, like what's your body doing? And we can put all of everything you're talking about is really your immune terrain, right? What does your immune terrain look like? How well are you able to respond to a virus? And so, is your immune terrain not functioning well? Is it compromised? And so we don't know as much about, so there's no studies that's correlating that because nobody's looking at that, right? But it makes sense to us that we want to, from a functional medicine perspective and from a preventive medicine, and it just makes sense that overall we want to understand if your immune system is functioning at its best. And I would put forth that if you have chronic Epstein-Barr, you've been dealing with Lyme, you have any other kind of virus, you have chronic inflammatory disease like chronic fatigue syndrome, then yeah, I would say your immune terrain is not functioning well. You definitely are going to I would put you in the bucket of an impaired immune system or impaired immune terrain. You can measure natural killer cells. You can go and measure natural killers. That's one of the things we do in chronic Lyme people to see whether or not chronic Lyme people tend to be below 150 or even below 100. And so we can measure your natural killer cells, and those are things we can do. And so I would say, if you have the access to blood work from a conventional perspective, and you really want to understand if your natural killers and your immune system's working, even classic things like a CBC, your white blood cell count, and then looking at your natural killer cell levels could be another way to do that. And this is, again, immune terrain. And then how do we help all that work better? We make sure your gut is good. So you could look at secretory IgA, but secretory IgA, which is, for those people who don't know, it's often picked up in a stool test. So we do these stool tests to check the microbiome. Secretory IgA can be suppressed because there's a dysbiosis in the gut, and a parasite even. Sometimes it suppresses it, sometimes it rebounds it and it goes high. So, because it's fighting something. Anyway, so I guess the summary on that answer would be that while we can't correlate that immune function is really important, yes, it has not been correlated with people, with any studies that are being done for the people who do worse with COVID. But it's intuitive that we want your immune system to function at its best. And so that's why last week, I said, let's focus on how do you prevent getting the viral disease? Because just having the virus doesn't guarantee what's going to happen. What's going to contribute to your end result is going to be, the virus, the social factors that you probably can't do much about. How crowded are you? Are you taking the subway every day because you have to? And then there's your own biology. And that's where we want to do some work. And you improve your immune terrain. And so you can do some assessments on your biology. And I think that's your question. And so if you have all those things going on, yes, I would say your biology is probably not up to optimal function. You can evaluate it for sure, or you can just get going and start working on it. And that is, eating an anti-inflammatory, immune supportive food plan, which we talked about last time, lots of vegetables and plants and lots of fiber and antioxidants and cruciferous vegetables, and help you with detox and help your gut microbiome work better. And then managing stress, which I want to make sure we talk about today a little bit. It's actually, maybe I'll even take a pause and we'll do that for a second. And so in terms of stress, and then we want to make sure your gut microbiome is really good and really healthy. And maybe next week's on Friday, if I have time, we'll focus on specific tools that I can leave you with for working on that stuff. I have a lot of resources. That's another resource place to go, is my Blum Health MD website. It's called blumhealthmd.com. And I have all of my book stuff. I wrote all this in my books, and there's all online downloadable stuff and free. I have a free, on that website, you can download my Heal the Gut chapter. There's a free download on that website. So, you can go over there and learn more. Okay. And then there's toxins, lowering toxin load. And you can be doing all this work now while you're quarantined at home, to improve your immune function. And if you have any of those chronic infectious or chronic things, then yes, it's a sign that your immune system is not doing well. And it could be a chicken egg thing. Maybe you have all those chronic infections because your immune system isn't doing well and can't clear them, or the presence of all those things are suppressing your immune system and keeping it from recovering. So we need to work on that. I don't like taking a lot of vitamins. If you could only recommend one or two, what would you suggest? Well, in general, you have to take vitamin D if you don't take it, because vitamin D is critical for just a healthy functioning immune system. So, and everyone's low, unless you live in the equator and you go outside at least 20 minutes without any sunscreen. And so, so I would say vitamin D is required as a general immune support. And if you had to do anything else, I would probably find a multivitamin that has 15 milligrams of zinc and 500 of vitamin C. If you want to eat food, eat an orange every day. You need to get your vitamin C. And so for COVID, zinc and vitamin C are the COVID. Vitamin D is you should be doing that anyway. And then for COVID, zinc and vitamin C are the two supplements you should take. Zinc, at least 15 milligrams, 15 to 30, 15 to 50, even up to 50 if you feel like you're getting sick. And vitamin C as much as you can take. I mean, I am prone to kidney stones, so I don't go over 1,000 a day unless I feel like I'm getting sick. But 1,000 a day, basic. 3,000 if you're walking around being exposed. If you're going to work on the front lines anywhere, up to 6,000 a day if you get sick. What do you think about Dr. Oz's idea to reopen the schools by saying we wouldn't lose that many children? No, I don't know that that's exactly what he said. Don't be careful about taking things out of context. I like Dr. Oz. He really has a good level head in general. And so the problem, it's not about losing children. Yeah, we won't lose children. But the teachers, we lost so many teachers. There's so many teachers that died in New York City from getting sick in March when it was spreading from the end of February and early March. We lost a lot of public school teachers. And so the children will bring it home to their parents, to their grandparents, and to their teachers, and to the whole system. And so it's not about losing children, why we can't send them back to school yet. It's because the children are unwitting carriers, and they will go home and make everybody sick. Is it okay to take blood pressure meds and anti-inflammatories vis-a-vis? Yes, it is. Stay on your blood pressure medication, and you can take anti-inflammatories. Anti-inflammatory for me means curcumin. It doesn't mean taking Advil. So there's this whole thing about non-steroidal anti-inflammatories. So I would stay away from the Advil and type things if you can for now. But there's great herbs you could take. Boswellia is great for pain, and curcumin is great for inflammation. How does the virus affect the oxygen level in the blood? The virus only affects the oxygen level in the blood if you get the pulmonary effect, the effect on your lungs. The overwhelming majority of people go through the COVID disease and they do not end up having any drop in their oxygen saturation in the blood. It's when the oxygen starts going down, that's when you end up needing to go to the hospital because you need to get oxygen. And so the next stages in your, for those people who are going to develop respiratory complications, they're the ones who end up with low oxygen in the blood. And I don't know the statistic on the percentage of people who that ends up, but my guess is probably, 80% of people don't develop that. It's those 20% that end up going to the hospital or that end up developing respiratory symptoms. If I spray my blue paper mask with a disinfectant after using it, is it safe to reuse? I can't answer that. But how I'll answer you is that's a good question for Google. And I just saw, so I'm on staff at Greenwich Hospital, and I get every day their update, and I see they're doing such a great job over there, and they're taking such good care of their frontline people. They have capacity now. Their ICU, well, they've been sending, they always keep capacity in the ICU because they anytime they go over 20, they send people over up to Yale. But they have empty hospital beds now. They've come back down from their max. But I saw this morning, actually, I got on the update that I got is that they found there's a study or there's a process that was validated for reusing N95 masks, that it works and it's good. And so if you Google that, you have to find it. You have to find it. What I'm doing for my mask, I have a cloth mask. So I'm just washing it. I go out, I come back, I throw it in the washing machine. So I don't know what kind of mask it is, but if you really want to know, technically speaking, how to recycle the masks, there's been a big breakthrough in validating that you can recycle them and they can be treated in such a way to recycle them. And so go get that answer online. Okay. So I did the vegan-oriented autoimmune paleo diet for 4 months, and my RA and Sjogren's got so bad. Yikes. I was crippled with pain and inflammation. Finally broke down and started prednisone and methotrexate. Now 6 months later, I'm still on both drugs and I'm significantly better, but RA is still active. I'm sorry, I don't know how to answer you, but it looks like you really need a personalized sort of conversation with someone. So I would send you elsewhere for that. And if there's a specific question that you have, I mean, you're on prednisone and methotrexate, so you are immune suppressed for COVID. This is a COVID related sort of question. If you have a different kind of question or you want to ask my health coach, Melissa takes questions. If you go to blumhealthmd.com, that's blumhealthmd.com. There's a support button at the bottom right-hand corner of the page. You just click on it and you can send us in an email question. We can't give medical advice over the like this, but if it's just a basic coaching question, she can try to answer you, or at least guide you where you can get the answer. How long is immunity lasting for those exposed recovered from COVID? Still sorry, don't have that. Yeah, Gail, I don't have that answer yet. We don't know. But I'm a hopeful. Because of what we know from all previous viruses, it would be expected that at a minimum it should last 6 to 9 months, or at least to take us through until there's a vaccine, or at least definitely to take you through the fall for sure. So, and by then we will have more information. So as long as we know you have good IgG antibodies, if you have them, then we will know that if it will prevent you from getting reinfected, which is really the most important first question to ask. Is we might not have how long, because we're only a couple months into this. So how long we might not be able to answer yet, but what we need to answer first is, if you have the antibodies, does it protect you from getting reinfected now? And those studies we're going to have in the next several weeks, I hope. But we don't have them yet, but they're in the process. I know they are. The recommendation is to take vitamin D. My vitamin D is low. Even I take high dose vitamin D. Why? Sort of outside the scope of this conversation, why somebody has low vitamin D. There's genetic differences in how people manage vitamin D. How well you absorb it. There's, I would have your doctor measure your 125 vitamin D. Sometimes the vitamin D comes in, but it gets sent quickly downriver. it's an upregulation of the system that breaks down and takes vitamin D and takes it into the next step in its pathway. And so some people have low 25 vitamin D, but they have high. So for you, I would want to measure the 2 different kinds of vitamin D in the body, not just the one, because you might be converting to 125 vitamin D very quickly, which is a reflection of like an underlying inflammatory process, which you clearly have. And so in your case, you don't want to keep giving high doses because you're just sending the vitamin D into a downriver. So that's one reason. So you can ask your doctor to measure 125 vitamin D. Fit active. Oh, this was the same person, but the mental mask, not eating gluten or nightshade. This is the person on steroids. And for some of you who are on steroids and methotrexate, maybe this answer will be helpful to you. Right. Yeah, you know what? Send your question. That's a health coaching question. She wants to understand about doing the elimination diet, if she could really learn and find out anything from that. Please go send that into Melissa, right, from Blum Health MD website, okay? Where do you get your hair cut? Thank you. That is the greatest question. Talk about lightening things up, right? I haven't gotten my hair cut, and you're gonna all see my hair's gonna get darker around my face as the time goes, and you're gonna see my gray. We're all gonna have a lot of fun. I go to Divashan in New York City. I actually do the little trek to the Upper West Side, and I go get my curly hair done there. They used to have a place in White Plains, but it's not there anymore. But I go to a curly hair place. Thank you for asking that. Sort of lighten things up. And yes, isn't it interesting what's going on? All of our self-care beauty routines, or just nails and hair and grooming type things, are we're living in it a different way, aren't we? Right after you started, there was a horrible buzz and it crashed my computer. Am I the only one? Oh, so sorry about that. So somebody had a buzzing and her computer crashed. I think that's just you. Sorry, because nobody else has said that. I mentioned in one of my meetings last week about prick finger testing. So I told you about that. It's coming. The finger, that's for antibodies, and I shared that information before. Is it the hypertension or the meds for hypertension that put people at risk? They're not thinking it's the meds. It's the hypertension. It's the hypertension, and it's not just even the hypertension. It's people with hypertension are more likely to be overweight. And so it's looking like obesity is the big common factor between all those people that are the biggest issue. And that's also why some of the younger folks that are obesity, there's people in their 30s, 40s, and 50s who are obese. And so obesity seems to be one of the big problems. And so there's some underlying sort of malfunction in the body when there's obesity present that changes things. And there's a lot of people looking into that ACE receptor piece, but don't stop your blood pressure medication. It's the medication is not the problem. It's that there's some underlying mechanism that they're trying to figure out. But yeah. Do the cloth masks do anything? So here's the thing about masks. Oh, and I'm going to sneeze. Excuse me. Right? Sneeze into your arm, not out here, but I'm not sick and I've been quarantined at home for a month. So here's the thing about the mask, and this is why you wear a mask. I have a cloth mask, and I actually hope I have another batch coming that I ordered like a month ago. I'm still waiting for, but at least the 4 of us living here, I have 4. We each have our own. Here's what the mask does. The mask prevents you from touching your face, right? So really important. But I'm sure a lot of you have seen these AI sort of screens of like people sideways and they cough. And then they watch the particles and how far they go, or they sneeze and you go achoo, and you see like how far your particles go across the room. And it turns out that the particles actually can go 6 feet, 10 feet, 12, like across the entire room when you sneeze or cough. It's not a big dose of it, but some of them end up making it really, really far. And so what a mask does is if you cough, or if you sneeze, it doesn't mean there's nothing that's going to come through the cloth mask, but it means that you're not going to projectile. You're not going to go as far out. So if I wear a cloth mask and I'm sick, I'm going to protect other people, because what will get through the mask, there'll be much less, even if it gets through, and it's only going to go like a foot or 2 feet in front of me. And if I cough or sneeze, I don't know, can't tell you with a cloth mask how far out it's going to go, but it's going to go much less far than it would if I wasn't wearing the mask. And so it's to protect it. So to keep the 6 foot social distancing, we still do that, the spacing, and we wear a mask, and that keeps it so that the 6 feet is adequate. And that's the way I look at it. So I don't want to be around anybody I don't know that's also been quarantining. Like in public, I want everyone even 6 feet away from me to be wearing a mask, because I don't want them coughing or sneezing even 6 feet from me, because their droplets from their mouth will still come across 6 feet. So that's the reason why, even when we go into phase 1 and phase 2, you all need to wear a bandana or a scarf or a mask. Just wear something across your face. Again, keep you from touching your face. It'll keep you from inhaling. If someone coughs or sneezes near you, it'll keep it from, at least, some of this is about the dose, right? You want to have less of exposure to it's how much virus all at once you get exposed to. A couple little, we don't know what the dose is you need in order to even get sick. It might be just a few little particles, you won't get sick, and you need a certain inoculum, we call it, like how much you get inoculated with. So you want to reduce your inoculum as much as you can. I might need to take a 10-day round of antibiotics. If so, what are my best actions going forward? Oh, okay. Well, you know what? You can definitely just ask Melissa that. So this is from somebody who sent me a message. Now, if you want everyone to see I didn't say this before. If you're putting up a question and you only write it to panelists, I'm the only one who's going to see the question. If you do it to everyone, there's a little toggle when you put your message. Choose everyone if you want me to say your name. So this is just to me, so I'm not going to say her name. I know. So this is someone who's been working with us to heal her gut. She's been in our arthritis challenge. I have an online arthritis challenge program where we do group work with the coaching, and I teach classes. And so she just is finishing our arthritis challenge. Good to see you. So you needed to take in a 10-day course of antibiotics. That happens. So anyone who needs to take antibiotics, you can protect your gut by taking an extra probiotic called Saccharomyces boulardii. So you take that with every antibiotic you take a boulardii, and then you double up on your regular probiotic, and you just take 2 at night before you go to bed. And then we just work on recovering. Don't worry. It will not set you back too much. We will help you, and Melissa will help you. I'm not worried about COVID at all, but just wondering some best practices for reducing inflammation in the here and now. The stress is really taking a beating on my hands. Yeah, no, I know. And so this is, again, for reducing inflammation. It's anti-inflammatory diet, meditation, go for a walk, some sort of stress relieving process for yourself every day, gut microbiome in general, and detox, right? And so this is my, get my book, The Immune System Recovery Plan. It's a 4-step program for reducing inflammation, a 4-step program for optimizing your immune function. It's all of that. And that's for the here and now. That's for what we can do. That's for the immune terrain. Okay, so that's what you need to do. So I sort of talked about the masks. I don't know that you're just going to get whatever kind of mask you can get. You don't need an N95 mask unless you're in the hospital. Okay. Do you know when I'll answer the questions? Do you know when Dr. will answer questions? Oh, sorry. Yeah, so in general, I know the questions are sort of towards the end. So I tend to do 30 to 40 minutes of talking, and then we answer questions. This week I read that the virus in severe cases impacts, damages the heart, the kidneys, the liver, causes blood clot, sepsis. Yes, 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 yes. Yes. How to devise a protocol and make a diagnosis in time when so many different systems can be severely damaged. I think the way you need to think about it is that in different people, it's showing up differently depending on your biology. And all that damage that they're talking about is what they're seeing in the hospitalized ICU patients. And so I think there's just, at the end, when things get really bad and you drop your oxygen saturation, I think a lot of that damage probably has to do with cytokine storm as well as hypoxia. And they're figuring that out. But that's really for people, all those damaged organs are what you see at the end. You know, as people, there's this moment, it seems, when people sort of drop off a cliff. They like seem to be doing okay, and then they just crash. And you see multiple organs are involved at that point. And I don't know that we really know. And the overwhelming majority of people never get there, right? They're still back here, you know, 80% who just go through this and have various different kinds of symptoms. Now people have digestive diarrhea symptoms. Sometimes it's a lot of headaches and fever. Some people don't really have much fever. Some people have a cough, some people don't. And so that's the mystery here. And we're going to learn more and more about that. Disagree about Plaquenil. Many doctors are speaking up that patients are getting better within hours after using. So a lot of doctors are having great success. There was a French study way back. Yeah, I know. I really want Plaquenil to work also. And I'm not saying definitely no on Plaquenil. There's a lot of Plaquenil studies going, a lot. And we're still waiting. And definitely anecdotal. I think that Plaquenil is going to have its best effects early, you know, when people first get sick, as opposed to the very, very ill people. I think so part of it is the studies need to be done on, like, it's who, you know, when you give it to them in the course of their illness. The French study were done on people who weren't that sick yet. They weren't in that very ill, hospitalized, heading down, or the ICU people. And so right now the 3 studies I talked about are for the very ill. And I think there's a lot of studies out there on Plaquenil. We're waiting, but they're not using that right now, the randomized trials, the ones that are really focused on the very ill people. I'm not seeing them talk about Plaquenil there. There's a lot of Plaquenil studies in place. So I'm hopeful about Plaquenil too. It's just, there's so many. So here's the other thing I'll just say to you. I understand there are case studies that doctors have said, but Plaquenil has been studied for 4 weeks already. We've had a lot of Plaquenil studies going on. It was the first thing studied. Why haven't we heard more good news? So I don't mean to be negative. I want it to be good. And I read all those early studies too, and all those anecdotal studies. And certainly there was a lot of myth and hype about it. I ordered it for some of my patients, you know, and so I understand. And I'm hoping. I think I'm hoping it'll end up being good for early, for early on when people first get sick. But like I said, there have been so many studies started on Plaquenil, and where are the results? You know, we should be finding something out already about those, because those were studied before anything else. And since we haven't heard, I'm just wondering if that's not a good thing, if, you know, that might not be a good thing. And I did just read something yesterday on Plaquenil that was like, nah, it wasn't so, it helped people with symptoms, but the outcomes didn't change. Something along those lines. I recently read about a neurological component. Yep. So the question is about, we're now reading that it's affecting the brain. You're going to find the virus is going to go, you're going to have effects everywhere. We don't know whether it crosses the blood-brain barrier. We don't know whether or not the neuro effects are from cytokine to, you know, the inflammatory, what we're calling the cytokine storm. Again, there are different people who are susceptible. You know, there's a blood-brain barrier. Some people have you know how we have leaky gut? You know, a lot of times I talk about damage to the intestinal lining. Well, they can be damage to the blood-brain barrier. It's called a leaky brain. And so for people who have impairment already in their blood-brain barrier because of other systemic imbalances or inflammatory processes in the body, maybe those are the folks that are going to be more likely, right? And so to end up in the brain. So I would just say, let's not go down a rabbit hole of focusing on organs that are involved. It's still a terrain, environment, ecosystem issue. We're still going to work the same way. We're still going to work on the antiviral supplements. You're still going to work on your gut health. Work on a leaky gut. You treat your leaky gut, it treats the leaky brain. Okay. So we still work on microbiome. You know, you're still just going to do all those basics. I'm not aware there's any way to go target the brain or target the heart. Although I love CoQ10, I take it every day. You know, CoQ10 is just a cardioprotective. So, you know, you certainly can. I do that anyway. I wouldn't go start taking it because of the COVID epidemic. I'm just saying, you know. So, but yes, we're going to hear that all the organs are affected, and especially for a certain subgroup of people that get the sickest. And I would say that when you look at the obese, metabolic syndrome, diabetes, hypertension, cardiovascular disease group of people with there's a chronic inflammatory underlying process. Those people have more inflammation in their joints. They're going to have more inflammation. They're going to have more, all their organs are going to be more susceptible because of the chronic underlying inflammation that's brewing around in the body already. And so, so I think it's really important to go upstream and remember that we have to be working on the foundations and not specifically necessarily until we know more about what's happening with the brain. Those are reports that are just coming out now. Where was I? Can you please spell the second treatment you mentioned? Oh yeah. In addition to remdesivir, that was Tosila. I know, I hate that name. I'll tell you right now. Treatment. What is my treatment? Yeah, I talked about TOC, Tosila, TOCILI, ZUMAB, tocilizumab. That's one of the cytokine storm treaters. You know, it inhibits, it squashes IL-6, interleukin 6. And then the other one for the altitude sickness, that's Diamox, DIAMOX, or acetazolamide, which is ACETAZOLAMIDE. Diamox is easier to spell. Question regarding individuals who get the virus seem to get better, then get presentation of illness again with more serious symptoms. Have you heard of people who 10 days after no symptoms then get more serious symptoms like vomiting, more lung tightness, and difficulty breathing? If yes, no. So the question is, there's a very small group of people who seem to get better and then get worse again. And it seems maybe they didn't clear the virus the first time. And so does this happen to everyone? No. I think that's more of the exception. And so the question is, did they didn't clear the virus the first time? I think we have to really evaluate each of those people individually, right? And to figure out what happened with them. Because certainly in the healthcare worker population, they get better, and then there's so much exposure in terms of, again, that word of inoculum. Are they getting re-exposed and re-inoculated with more virus before they really had a chance to develop enough immunity? Because what happens is you need at least 2 weeks to 3 weeks generally for your immunity to get robust. And so there's this little window where you're not really immune yet, and if you get reinfected too soon or re-exposed too soon, you could get another dose of the virus. And so we have to figure out if those people's immune systems just aren't that strong and they didn't clear it well to begin with, and that it was or some stressor came along and it sort of set them back, like more exposure or something else like stress or there's something else. So I think the most important answer to your question is we have to dig into what exactly happened with those people. And they're a minority of people, but they are important people for us to study. And we don't really know the answer to that yet. Asthma is less likely to be a high risk group. I mentioned that. Yep. But those with a suppressed immune system still are high risk. Correct. Yes. I just know that I saw a report about asthma and that they were surprised that the people with asthma were not ending up in the high risk group. That's all. And, but I haven't seen any information yet about people on prednisone, for example, or people on other immune suppressing medication. So if you do not acquire the antibody and have a suppressed immune system, will I be one of the small percentage that need to stay home longer? Yes. You're still considered in that high risk group, even though you're still in that group that need to be protected. And with the whole go back to work stuff that's going on, or, these phases, your employer has to make accommodations for you to let you work from home until this thing's really under control and until we understand more about the risk, right? And stratifying people high risk. For now, you're considered high risk. Yeah. What lab do you use for the antibody test and the diagnosis test? Right now, I'm using a Periomics for a diagnosis test. That's a throat swab. That's a kit. And I'm using KBMO, is the one that's doing the antibody test. Is there any way to hear these talks if you are working at the time of the meeting? Yes. I'm a teacher. Yes. Good. You're welcome. I'm on YouTube. We put these public on YouTube. So go to YouTube, put my name, and put Friday office hours, and search for it, and you'll find it on YouTube. If I took the 3-month gut health challenge at the end of 2019, can we get the antibody test? So here's the thing, no. So if you did a group online program with me, that doesn't make you a patient of Blum Center. That's because we never had a one-to-one relationship, and you're not in my medical records in the office. And so I love all my challenge group people that we've done for the past few years. I do online groups. To make what we do more accessible to everybody. But no, you'd have to contact the office, and you'd have to formally become a patient of Blum Center for Health. What about false positive or negative with fingerstick test? False positive, false negative, that's another whole conversation. That's actually the way the test has to prove that it has a low rate of false positive and a low rate of false negative in order to get approval by the FDA, in order to be a valid test. That's really what's holding everything up. So there's 2 parts to a valid test. First, you have to have the way the test is done. So right now, the blood test has been validated. It's called sensitivity and specificity, and that speaks to the false negatives and false positives. You want to have your sensitivity and specificity at least 90% or higher, which means you'll have 10% or less false positives and false negatives. So there are always false positives and negatives in all tests. None of them are ever 100%. On a population-based level. But there's a rule to those numbers. They have to be in an acceptable place in order to the test to be offered to the public and to get this FDA emergency approval. So false positives and negatives have to be okay. And then the second part of your question about fingerstick, that's actually what's holding it up, is that they're doing validation studies comparing a fingerstick to a blood draw to make sure that the false negative, false positive are the same, that the same accuracy holds up for a fingerstick when done by a patient by themselves. So that's in the middle of being worked on. Can you go to a draw station, or is that for those labs only, like the Hospital Quest LabCorp? No, not available yet, which is why I, as a service to our patients, we have companies that we can send to your home, to have you draw the blood now, or you can do a fingerstick when the fingerstick kits come out. Eventually, you should be able to go to a draw station. So for example, Quest, LabCorp, or the hospital, they generally will not let you do outside kits. You can't take your kit and say, here, can you draw my blood? They generally won't do that. That's why the phlebotomist is required. But once there's a fingerstick, you can do that yourself. Can you describe early hints of respiratory problems? Would you be looking for in early stages of illness? No fever, slight tickle in throat, but some occasional pressure in the chest. Can do deep breathing. Just wondering if you would feel pressure on breastbone or back. Never had experience. Shortness of breath, if you can hold your breath and count to 10, right, there's that little trick. Really get really out of breath going up the stairs. Get really out of breath walking across the room, like things that really shouldn't bother you. A little tickle here could be reflux. With all the stress, a lot of people are experiencing some reflux, and so that could be that. So shortness of breath is sometimes you can feel chest tightness, like you can feel restriction in your ability to take a deep breath in. And so really, if you can hold your breath for 10 seconds and not cough, and if you can, coughing sometimes is the first thing that happens before you start feeling trouble breathing. But it's really getting out of breath, doing things you just should not be getting out of breath doing. What are the Th2 syndromes for autoimmunity? Can you use those for them? Yes, you can. And those are things like Hashimoto's, organ-specific autoimmune conditions that are organ-specific. And so things like Hashimoto's, which is a very common kind of condition. You can do it for rheumatoid arthritis, which is joint. You can do it for really all other autoimmune conditions for the most part, other than the ANA positive, lupus, and cousins, rheumatic diseases. Came off Enbrel for psoriatic arthritis. Sounds like I could go back. Taking Tylenol and leave 1 a day. why would you go back on Enbrel? Enbrel is an immune suppressant. So I'm not telling you to, if you're off of Enbrel, then that's a good thing. So you don't want to suppress your immune system right now. How much vitamin D? 2000 is a good average dose for most people, but I tell people get your levels done by your doctor and titrate up or down depending on what your blood level is. You might need more, you might need less. I take 5,000 a day, but I wouldn't tell the general public in a group. I can't give you medical advice on your exact dose, but I generally tell people 2000 is certainly a safe place to start. Is it okay to take zinc and vitamin C at the same time? Absolutely. I recommend taking them both at the same time. A multivitamin for women in her 60s. Absolutely. I like, you can do Designs for Health, twice daily multi, 2-a-day multi. You can do, I like Pure Encapsulations has the ONE, the 1-a-day. I like Metagenics has a phyto multi. Orthomolecular has a mitocore. I like all of those. Does Boswellia, a question about Boswellia, it's just an herb that's good for pain. Is COVID affecting the brain? We talked about that already. Is continuing to use a CPAP okay during this time? I've been worried about the air being forced into my lungs while I'm healthy in case someone witting exposure. Somebody asked me about CPAP before in one of my other talks, and I have to wind down and we've got 2 more minutes. So if I don't get to your question, I'm sorry. As long as you're quarantined, you can use CPAP, but if you start going out into the world, I too worry about, you don't want the virus, if you get exposed, to be pushed into your lungs. So be mindful of using your CPAP machine, especially if once we go out in phase 1 and you start getting exposure again. After mild, possibly COVID symptoms, no testing in Massachusetts. I continue to have a persistent cough. What would you suggest for treatment? High dose vitamin C. 3 to 6,000 milligrams a day, and zinc. I would go up to 30 to 50 milligrams a day, and see if you can get the antibody test, because that's how you're going to know. You want to wait to do the antibody test till at least 2 weeks after you had your first symptoms to give yourself a chance to get the antibodies, 2 to 4 weeks even. So it's even better in that period of time, between 2 to 4 weeks later. I've taken 2 of your online. Let me just see how many questions I have left. Oh, guys, I'm sorry. I'm a graduate of FMCA. I would love to help you pass this information. Do you have a need for any more health coaches? So Kim, you can go to blumhealthmd.com, send in a message to Melissa. The support button is a message, goes directly to Melissa Rappaport, our health coach. So reach out to her and she will be the person to see if there's a way you can help us. Can zinc give me hand rashes? I added this to gut cleanse and want to know if I can restart zinc when hand rash is healed. Yes, you can try zinc again. It's always good to, if you take a supplement and you get, something happens, you think it's a side effect, you're not sure, you can take it, you stop it, and then you reintroduce it again and stop it, wait till the rash goes away, and then try it a second time and see if it does it. If you've not been sick, can you have the antibody? It's possible. That's what we're trying to figure out, which is why it's interesting to do the antibody. If you've been exposed to somebody who had it, and there's any reason to think you had exposure, then you might want to do it and see maybe you're a carrier and you did not get sick. So you can. Multivitamin with antioxidants, yes, good for women 65. Is there a decrease in vitamin D absorption if you take it with vitamin C? Not that I'm aware of, but you can increase absorption if you take it with ADEK, the other fat-soluble vitamins. Will the QA part be included in your recording? Yes, this whole thing is going to be part of the recording. It's still recording. You're welcome, you're welcome, you're welcome. I didn't recommend anything in particular for Hashimoto. Somebody asked me if they could take astragalus or mushrooms or natural killer boosters and for autoimmunity. And I said, and that was an answer to that. So if you have Hashimoto's, you'd be in the bucket of people that that would be fine. Go back and listen to the earlier, for someone who has the virus but has never been able to tolerate C, what is the most benign form and brand you would recommend? I don't know. You're just going to have to try different stuff. Buffered vitamin C for sure, and just do low dosing, and you can just spread it during the day. And when you mentioned the high risk factor with obesity, clinically obese, they're defining it, I don't know what the definition of obesity is, but yeah, it's more clinically obese. But the more overweight you are, the more, and then it's clinically obese. And then if you're overweight, the question is, do you have hypertension and heart disease and diabetes or other things that work with it together? So in either case, losing weight would be good for all of that. So I've taken, last question, and sorry if I don't get to all the questions. I think I got to most of them. I was asking when you knew it would be safe to schedule surgery in a hospital. My husband is high risk of diabetes, heart procedure 7 months ago. Yeah. He needs to have surgery to remove tumors from his pancreas. His surgery was originally scheduled but postponed. Our health department and the hospitals don't release 19 for hospitals. I would say this is a tough one, and I would just follow the guidelines and choose and ask the hospital how they're separating people. And I think it's going to be safe. Whenever the hospital opens up and says it's okay, I would believe them. So it's not really up to us to decide when that's safe. I think the hospitals are doing an amazing, amazing, amazing job. And I think that I'm just so proud of all my, fellow healthcare workers out there. And I think that as the phases go, they're going to start opening up surgery as the hospitals catch up. And so hopefully in the next 2 weeks, when we move into phase 1, because the admissions in the hospitals, they won't be just treating COVID patients. And we understand how it's transmitted. There'll be safe practices, enough PPE, all of that. And so just follow the guidelines of your hospital and your doctor, and it should be fine. All right, guys, listen, I'm sorry. People keep posting more questions as we go. And you're very welcome. You're very welcome. And for those of you who want to email us, I gave you the email addresses. So admin@Blum Center for Health is perfectly good as another way to go. You can also call the office. If you can't remember anything I said about the testing and you just want someone to explain it to you again, you can always call our office. You know how to get that number. And Ariel will be, or one of my wonderful ladies that take care of the office can help you. Okay. Stay well. I'll see you next Friday. And just stay home and stay well.